Dear colleagues, dear chairs, thank you, Kaya, for the nice introductory words. I didn't understand them, but I am very happy to talk here. And now my task for the next 20 minutes is to talk about what should be the ideal method for remnant liver evaluation in major hepatic resections. So these are my disclosures. I have the following agenda for you, some introductory words, then I will talk about a new guideline. I think this is the first ever published guideline on this topic. I will answer the question in which patients pre-op functional assessment routinely should be performed before major hepatic surgery, which assessment methods can be used. Then I go to, because I don't use any method that is on the market, and so I just will give you an insight how we work at the charity, so how we do it, and then a little summary and take-home message. So introduction. First of all, we have to talk about some definitions. So what is a major resection? Major resections by the Brisbane classification is 3 or more segments of the liver. But what is a complex resection? A complex resection is a major resection with additional vascular and or biliary reconstruction, so extended hepatectomies, trisectionectomies, these are complex resections, and also resections in pre-injured livers or livers with moderate portal hypertension are complex resections. So PHLF means post-hepatectomy liver failure, and according to the literature, in 9 to 30% patients experience this after extended resections. To classify this, we have the ISGLS definition. That means we have bilirubin and INR increase on postoperative day 5, and we have 3 clinical grades, A, B, and C, and B and C are the clinically relevant stages of post-hepatectomy liver failure. And post-hepatectomy liver failure is still one of the most frequent causes of major morbidity, and it's the major determinant of postoperative death. So CRPHLF would be clinically relevant post-hepatectomic liver failure. What is FLR? FLR is the future liver remnant volume. And what is FLRF? FLRF is the future liver remnant function. So we have guidelines. They were published this year in July, so very new guidelines on this topic. And these guidelines were from the EAHPBA ESSO and ESSR consensus guidelines for preoperative liver function assessment before hepatectomy. There's another guideline published this year in June about meprofenin hepatobiliary scintigraphy, but this is more or less a procedure guideline, and there is no comparison between the different methods for functional assessment, so I will not focus on this guideline, but for this talk I merely focused on the British Journal of Surgery guideline. What was the level of evidence in the new guideline? So this is from the authors themselves, and they said they had the sobering realization that most retrieved publications have a low to medium level of evidence. There was only one subject, what is a special liver function test, the so-called LIMAX test that we use at charity, that included 1+ level of evidence because there was one RCT. So in which patients routinely preoperative functional assessment of the liver should be performed? This is a question the guideline asked at first, and the answer was preoperative liver function assessment should be considered in patients that are scheduled for a major or extended major or complex hepatectomy with suspected or known underlying liver disease, or suspected or known drug-induced, that is STILI, liver disease, or chemotherapy-associated, that is CALI, liver injury. For instance, sinusoidal obstruction syndrome, if oncologists have used oxaliplatin before, or chemotherapy-associated steatohepatitis, what is called CASH, if the oncologist has used irinotecan chemotherapy before. So what other clinical considerations for functional assessment should be done? The main risk for significant CALI, SOS or NASH is 3 to 6 months of systemic chemotherapy, including irinotecan or oxaliplatin, and also diabetes or obesity is a risk factor for NASH and for insufficient liver function after major resections. Of course, not all diabetic or obese patients need sophisticated liver function assessment, but in major resections or in complex resection, it is advisable to do it. Next thing, signs of cirrhosis or portal hypertension on imaging or in laboratory parameters. What kind of, how can we see this? We have liver surface nodularity in the contrast-enhanced cross-sectional imaging. We have splenomegaly. We have portosystemic collaterals, ascites or thrombocytopenia. This is everything you should have a look at on your cross-sectional imaging. So what parameters for time point of liver function assessment should you consider? And it is very important to see the interval from pre-treatment. That means when was the last chemotherapy? It does not make sense to do functional assessment one day after the last chemotherapy cycle, because liver function, of course, will be reduced then. Then when is the surgery planned? Do we have maybe time to adjust our strategy? And repeat testing should always be performed in the case when we decide for augmentation of the remnant liver. So repeat testing should be done, one test before augmentation and one test after augmentation. What about non-tumoral liver biopsy? The guideline here was very strict. It's not recommended. But I would say in some cases where you have very complex situations or borderline situations, even if you plan an open resection, you might go and start the operation with a diagnostic laparoscopy to have a look at the liver remnant before you open up the patient with a big incision. So, in which patient routinely functional assessment? Some words about future liver remnant. As you all know, healthy parenchyma. This was already published by Clavian a couple of years ago in New England Journal of Medicine. With healthy parenchyma, you can do extended resections, and future liver remnant volume should be about 25 to 30%. But in the case of injured or damaged parenchyma, as I already mentioned with chemotherapy after oxaliplatin or irinotecan, you need much more future liver remnant volume. And very interesting from Narita et al., published in Annals of Surgical Oncology, if the patient has a CALI or a CASH, we have a 10-fold rise in postoperative hepatic liver failure if the future liver remnant volume is below 44%. So which assessment methods can be used? And in this section I will focus only on the functional MRI and on the LIMAX test, because with these two functional assessment methods I have experience. But before we go to the more sophisticated functional measurements, of course we have to do the basics. So basic liver lab with liver function test, GGT, bilirubin, albumin, platelet counts, INR, hepatitis virology, and basic clinical assessment with history taking, comorbidities, chemotherapy, when was the last chemotherapy, is there a hepatitis, is the patient obese, is very important and should be mandatory information for all liver resections, not only for the extended resections. Clinical risk scoring should implement the resection extent and also kidney function. Kidney function is very important, especially in extended resections. If the patient is on dialysis, I don't have very good experience with dialysis patients and extended resections. Usually this can happen and become a disaster. So INR is important, and the ALBI and APRI score should also be calculated. So liver volumetry from cross-sectional imaging, from contrast-enhanced CT or contrast-enhanced MRI, I think is mandatory information for extended and complex resections and if there is potential liver dysfunction. Then the more sophisticated functional assessment, like for instance ICG retention rate or LIMAX test or special scintigraphy or functional MRI, based on institutional expertise and availability, is also, in the opinion of the guideline authors and my opinion, a mandatory information for the extended and complex resections and for potential liver dysfunction. So depending on the result, you can still, if the result is not good enough, you can still change strategy and can make an indication for augmentation. And what kind of augmentation should be used, we will hear in the next talk. I think Fatih will talk about it. What is better, PVE or HVE or maybe ALPS procedures. What about liver stiffness measurements or hepatovenous pressure gradient measurements? The guideline says it can be used in patients with suspected or non-portal hypertension, but we would say preferably we do the liver stiffness measurement by ultrasound because it's non-invasive. So we go a little bit more into detail. What about functional MRI? This is a study published by my colleagues from radiology, from Charity in European Radiology in 2019. And they were able to predict liver failure after extended right hepatectomy following right portal vein embolization with gadoxetic acid-enhanced MRI, so Primovist MRI. And the study design was they did a pre-PVE MRI, 36 patients, then the PVE was performed. After 14 days, another MRI. After 30 days, another MRI, also for control of hypertrophy. Then the extended right hepatectomy was performed, here in 33 patients. And then 10 days after the operation, another MRI. So, and these are some of the results. I hope we can see it very good also in the back. If you look at these are two patients. The first patient on the upper part here is a patient with cholangiocarcinoma, Klatskin tumor, and this patient did not experience hepatectomy liver failure, and before PVE you see kind of same tracer or contrast enhancement in the liver, but after PVE, as you can see, there was hypertrophy in the left lobe and not so much uptake of the contrast media in the atrophic right lobe. And over here, on the other side, this was a patient that experienced post-hepatectomy liver failure, a patient with multiple colorectal metastasis, and you see before PVE and after PVE, there was no difference in uptake of the Primovist in between both lobes. So they did a lot of calculations and a lot of radiological stuff that I don't really understand very good, but they could show with a good AUC and a high sensitivity and specificity that with the functional MRI they were able to predict post-hepatectomy liver failure. And in conclusion, they said Primovist enhanced MRI performed as an imaging-based liver function test before and after PVE can help to predict PHLF, and the risk of PHLF can be predicted as early as 14 days after the PVI. So after this conclusion, I always ask my radiologists, okay, this is very good, you have good results. When do we have the one-stop shopping? I want to send you a patient, you just do the MRI and you can give me information about diagnosis, staging, vessels, biliary structures for OP planning, volumetry and function. And this is still something for the future. We still, unfortunately, need more examinations and not only one-stop shopping, but maybe in a couple of years we can do this just with one MRI. The next thing I want to focus on is another liver function test. It's a so-called LIMAX test, what was developed in my department. Dr. Stockmann, Martin, he did a lot of publication and a lot of effort in this, and the first publication was in Annals of Surgery in 2009. And to briefly explain to you how this works, this is a non-invasive test. The patient gets C13 marked metacetin intravenously. The metacetin is a prodrug of paracetamol and is metabolized in the hepatocyte in the CYP1A2 to paracetamol and CO2. And the concentration in the C13 marked CO2 in the exhalation, you can test the liver function. And to show you that this is a reasonable test, we performed these measurements during liver transplantation. So in the anapatic phase, if you do the test, there's absolutely no liver function. And everybody, I think, would agree in an anapatic phase, there's no liver function. So after reperfusion, if you perform the test, you see how this value is increasing minutes after reperfusion. And in the same paper, we described some patients who had this test, and you could see how the liver function was before the operation, then after the operation. We have different curves, and this is the curve of the patients that received or that experienced liver failure. This is patients with severe complications, and these were patients with a normal course after the operation. So the test was able to separate patients that experienced liver failure and patients that had a normal course. Next paper on the LIMEX test is a randomized clinical trial that compared liver resections with and without the perioperative assessment of liver function with this special test. So this was a multi-center randomized international trial. There were 148 patients randomized. The intervention group was the LIMEX group, where the liver function test preoperatively and postoperatively was performed, and we had a control group where this test was not performed. For analyzation, in the end, we had like about 60 to 60 patients. What kind of operations have been performed in this study? There were right hepatectomies, extended right hepatectomies, left hepatectomies, extended left hepatectomies, but also some segmental resections and other resections. And to the results, if you look here at the time the patient had to spend on the ICU, or the time the patient had to spend in hospital, in the interventional group, the time in hospital and the time in ICU was significantly lower than in the non-interventional, in the control group. And in the interventional group, it was we also saw that there was significantly less major morbidity. So with this paper, we could conclude, or the group could conclude, that the perioperative use of this special liver function test called LIMEX improves postoperative management and reduces the incidence of severe complications after liver surgery. So how do we do it? Or how do I do it in my team? For the extended resections, we usually do a remnant liver volume function planning, how the LIMEX test is performed, I just explained, and then we always combine it with volume function planning. You need a very good radiologist for it, but if you're experienced, you can do this on your own. There's computer programs for volumetry. You don't have to do this with 3D, you also can do this with 2D data, and you have to measure out the total liver volume, the tumor volume, what you subtract of the total liver volume, and then you tell the radiologist what parts of the liver you want to resect. And then you can calculate the rest volume of the liver. And then you easily can, if you have the liver function test before, you easily can predict how much liver function will be left after the operation. And due to the many measurements that we have performed over the last years, we see that this correlates very well the estimated values and the values that we measured after the operation. So how we do it, we make basic clinical assessment and laboratory, and of course the scores like ALBI and APRI score. We do perform liver volumetry from cross-sectional imaging, from MRI or from CT scan, and we do functional assessment with LIMAX plus minus functional MRI. And we developed a kind of a charity algorithm for complex liver resections, or for liver resections in general. And if we have a look at it, you can, with the measurements, we have certain cutoffs over the years, and we can see how high is the risk for the patient for in-hospital mortality, and when we should refrain from operation, or when we can say, okay, this is a medium risk, we can try to do the operation, or this is an easy thing, we just do the operation. But I still would say in critical and complex situations, we would perform diagnostic laparoscopy, also in planned open resections. So to end this, I want to give you a little case presentation. This was a 74-year-old female. She was obese, BMI of over 30. She had a locally advanced gallbladder carcinoma, so the segments 5, 8, and 4 were with carcinoma, but she also had a right portal vein and a right hepatic artery infiltration and a biliary duct infiltration, so she needed a trisectionectomy. She had insufficient liver remnant volume and a slightly reduced special liver function test with LIMEX, so we decided to go for portal venous embolization. During the waiting time for hypertrophy, the patient experienced 2 episodes of cholangitis and needed re-ERCs. She had concomitant renal failure, but finally creatinine was normalized and infectious parameters were normalized. So we calculated a sufficient remnant volume of about 40% after the hypertrophy and sufficient calculated remnant liver function with a remnant LIMEX of 180. So the open operation was scheduled, but we started with a diagnostic laparoscopy. And this was what I found in a diagnostic laparoscopy. So even if all the values after the many efforts that we had done were okay, I found this liver didn't look so good for a trisectionectomy. So I made a biopsy and gave it to the pathologist at frozen section. And we found a fatty, he found a fatty degeneration of 80% microvascular and 10% macrovascular steatosis and a fibrosis of grade 3. So I decided in the team that we don't perform the trisectionectomy, we break up the OP and referred the patient back to the oncologist for systemic treatment. So let me summarize. Post-hepatectomy liver failure stays one of the most feared and deathly complications after liver resection. Meticulous planning and remnant evaluation is mandatory in extended and complex resections and pre-injured livers. We recommend liver remnant volumetry combined with functional testing by LIMEX or other functional assessment depending on the institutional availability, for instance ICG, HB scintigraphy with SPECT. And in difficult or complex situation, a diagnostic laparoscopy at the beginning of the operation is advisable. Thank you very much for your kind attention.